All right, good afternoon. We're going to get started. So the focus of this session was, instead of giving a lecture or talking about different minimally invasive procedures, we wanted to sort of have more of an interactive discussion about how we take things that we're talking about in these lab-based sessions, and how do we recommend, or how do we go about incorporating them into the trainees' either training regimen, or how does a person that's just finishing their training adopt these things early in their practice, if at all? That's the topic of discussion. I think everybody, all of the proctors and people that you are working with, I think would agree that, you know, if you start your career and you go out and you sort of plant your flag that I'm a minimally invasive AVR surgeon or a robotic this surgeon, that is a very treacherous start. So that's what we're here to talk to you about, and hopefully if you have questions, that's what we want to make sure you're getting the right message from us. Because I think, especially for those of you earlier in your careers or just finishing training, I don't think the message is just go on out there and good luck. You know, it needs to be much more structured than that. So I'm going to start with some questions for the folks on the panel and for those in the audience. Tom, Ralph, do you think that somebody that's just finishing their training, I'm graduating, I got a job starting next year, I want to do minimally invasive surgical AVRs, what would your thoughts be on that approach? Tom, why don't you start with that?
You know, I have a lot of thoughts on this. I think currently in our current training paradigm, I think it's tough for a graduate to come out and start doing minimally invasive AVRs and complex mitral valve repair. But let's take a step back a little bit. You know, and I think that the technologies out there has been evolving at an exponential pace. The way we treat patients with structural heart disease and aortic disease has changed significantly. But our training paradigm has pretty much remained stagnant for the past 10, 15 years. And I don't think we're doing a good job at training folks to treat the disease processes. I think historically, surgeons have been defined by, you know, a scalpel and the use of the heart-lung machine. And I think the problem with that is that if you're defined by these things, then eventually these things are going to go away. We're going to be outdated and be extinct. And I think the better way of doing it is being defined by the disease processes that we treat. So I envision, if I were to kind of reorganize everything, I would love to have a way so that we can train folks to be valve specialists, train folks to be aortic specialists, and even coronary specialists. As a little bit of aside, you know, we've had some dialogue at the SCS, and we're in some dialogue with the board in the RRC, and we're entertaining an idea of having a separate pathway, and we're experimenting a little bit. You know, right now there's a cardiac pathway, there's a thoracic pathway. But we recognize that as cardiac surgeons now, if we're not graduating, and if you're not able to do TAVRs or potentially clips or minimally invasive, you know, you're out of the game. This is a discussion we'll have later on this evening, but I think that's the future, and that's kind of the direction we should be going in.
So Ralph, somebody's just finishing, they're joining your program. Are you going to just say, good luck, I know you want to do minimally invasive AVRs, here's the case for you. Let me know how it goes. What do you think about that?
We would never do that, and I would not recommend that you do that either. So, first of all, you know, let's put it all into perspective. And, you know, I'm a big believer in specialization in our group. And as someone who's had to mentor, you know, for decades, other cardiac surgeons on my faculty, you know, everyone needs a niche. And I think that's going to be an important thing when you go into practice, to find that niche. But the first thing you have to do when you finish practice is realistically have a really good grasp of what you're good at doing, what you're comfortable, and what you need help with. You know, and having trained surgeons for years, and trained residents, you know, there are definitely surgeons in our program over the last 20 years that have gone out and been able to do minimally invasive mitral and aortic surgery almost from the beginning. But I would have to say that they are probably a minority of the surgeons. They were technically gifted, but one of them was part of our just 2-year training. I think you can learn it in 2 years if you're at a program that lets you do a lot of surgery. So But there are programs in the U.S. where we hired someone who really was unable. We didn't hire. He was one of our extra fellows, a transplant fellow, came from a big program who still was really not even comfortable taking a mammary down. So that's where you have to assess your own skills, your own training. And the most important thing when you take your first job is not to advertise yourself as minimally invasive, is first to realistically assess, okay, I'm comfortable doing on and off pump CABG. Maybe you're not comfortable doing off pump. You shouldn't do it. First, just do what you can do well and safely. And if there's any question, and almost wherever you go, in a good practice, you will be mentored, and you should be mentored. If the practice is throwing you out right away, you know, with some rare exceptions of people who are really technically gifted, most people won't succeed without a mentor. So one of the things you have to decide, you know, what am I good at? What do I need mentors? And, you know, hopefully the practice provides you with a senior surgeon as a mentor. If not, that's a red flag, probably.
And you need to ask.
You need to ask. If they absolutely have no idea or don't even think that that's foreign, you probably need to be considering another job. And there's so many jobs now. I'd also put everything in perspective. The most important thing is to do safe surgery and not to have bad outcomes. The majority of cardiac surgery in the US is not done minimally invasive anymore. Now, I'm a huge advocate for minimally invasive surgery, but you go into a practice, I can tell you in our area, both in terms of the off-pump world and the robotic world, there's been so much bad surgery done that it's given a lot of it a really bad name among a lot of the communities. Now, while I agree with Tom about specialization, you know, the majority of people in the US who finish our training programs are going into private practice, often at very small hospitals. If all they were trained on doing aortic surgery, they'd starve to death. We polled the group of surgeons that we've trained that have gone into private practice, and the majority are doing both cardiac, thoracic, and vascular. So I would argue maybe we're not even training broadly enough, not that we should specialize. Now, there are exceptions to that, but, you know, you know, when you go out, just remember the rest of your life you're going to be learning, and you just have to have that attitude. And coming to courses like this, if there aren't mentors available in your institution, going to that. And then what I would really suggest is go slowly. If you're going to be doing, I think our fellows are very good for doing mini AVRs and some of them mini mitrals. But, you know, when you start, don't make, you know, a 1 or 2 inch incision. Make a bigger incision. And, you know, while we have, you know, make fun of man surgery, which I saw yesterday, at the same time, you know, at the end of the day, you have to do something very safe, and you have to do everything you can to limit your learning curve on patients. And we're all going to have a learning curve, but you want to try to minimize that as much as possible. And when you first go into practice, you know, you have a bad outcome. You know, the whole hospital hears it. You haven't built your reputation enough. You know, some of us who are senior, I can try something new, and if it went bad, they're going to go, okay, we'll give him a pass. But
Yeah,
you know,
I would say your first years is so crucial.
so especially if you're doing a really tough case, have a senior guy, and then if things go bad, they're all going to blame the senior person helping you, not you. And that's always that's what you want to do, and that's how we protect our young faculty. The last thing you need is someone who you've invested a lot of time and effort in trying to grow their career really flame out. So, you know, while I'm a big believer that minimally invasive surgery is what we're going to need to do to stay relevant, you know, it really depends on your treatment. There are definitely places in the U.S. that you come out and I think if you've had enough experience, you both have got, you know, the basics of doing it, and you have a mentorship with your professors who trained you. If not, then you have to develop that hopefully either within your group or outside, and then just phase it in. You don't have to do everything right away. It's in fact, it's crazy. And, you know, we've had just innumerable surgeons in our region come and go trying to, you know, first really learn how to do the operation really well and safely, and then start making it less and less invasive. But clearly there are places in the US where you've had a ton of robotic experience and feel comfortable, then that's great. Do it. But really, one thing we see that is often lacking in some surgeons coming right out into either our faculty is enough self-insight to realize, you know, you have to be honest with yourself. I mean, we're all not great at everything. You have to know, where am I in this spectrum, and when do I really need to call for help, and have like a totally low threshold for doing that.
Yeah, thank you. So we also have a couple surgeons that are relatively junior in their careers in cardiac surgery. So would you, either of you guys, like to comment on, how things have started for you? I know your boss is on either side, but if you can.
So I'm Marvin Atkins. I started here at Methodist about 8 months ago. Previously, I was a vascular surgeon in practice for about 10 years. I had a big interest in aortic surgery. Decided to go back and complete cardiac training. So I just finished up at Penn about 8 months ago and started here on faculty. You only have the first chance to make a first impression. You never get a second chance. And so what my goal the first year in practice was kind of aiming for maybe 150 pump cases or so. I'm not really trying to schedule 2 or more cases per day, try and just focus on that patient, make sure everything looks perfect. I've done a couple mini AVRs, but most of the stuff has just been open sternotomy. As they used to say, you can compromise on love, but not an exposure. So really make sure that you've got complete visualization and really safety is the key, because your cardiologist referring base, they don't really care that much about the size of the incision. They want their patient to survive, not have a complication, and have a short stay in the hospital. So I've really tried this first year to really just focus on safety and good outcomes, and then over this next year, then I'll start kind of pushing the envelope a bit.
I think a lot of important points were made, and I think the most important one is probably you can't compromise on safety or outcomes for a smaller incision because it's sexy or you find it interesting or what have you. And I think if you look over to thoracic guys, certainly VAC surgery has become more common, but in the last 10 years or so, but that was a learning curve too. And I think the first thing that outspoken surgical oncologists wanted to know is, can you do the same quality surgical resection if you do it through a smaller incision? And I think the same principle goes for cardiac surgery. The premise must be that you accomplish the same result. It's more a platform or a tool, but not really, the outcome shouldn't be any different. And so as far as, who should be doing those, well, I think if you look across the United States and training programs, well, the experience is, as much as we try to make it a conformity and sort of the same for everyone, it's not. I think everybody graduates with different numbers and experience and graduates with different kinds of exposure. So, and I think the goal can't be to make sure that everybody does the same thing. I don't think it makes sense. And I also see, and I would be interested to hear everybody's opinion on that, I see 2 important trends. One is the one that Tom alluded to, that there is a need for cardiac surgeons to evolve and sort of have increasing competition from interventional cardiologists with transcatheter therapies in the structural heart space, with PCI and the CABG side of things. And so there is some push to specialize. And I think it is in tune with all of medicine that is getting more and more subspecialized. Everybody is subspecializing more. On the other hand, if you look at the job market and graduation trends in the United States, there's a huge discrepancy between the need for cardiac surgeons and cardiac surgeons graduating. And I think most jobs that are out there are jobs that require people to do cardiac surgery, thoracic surgery, and vascular surgery. To some extent, I believe it's because it's cheaper for the hospital. It's cheaper for the hospital to hire one surgeon that does it all. And so there's probably some policy action needed and advocacy action needed to halt that trend, because it's not really timely anymore. I think it's an outdated concept. But the reality is that there's a lot of jobs out there. There's a lot of demand for surgeons that do a little bit of everything well. And I think those are 2 different trends. One is towards more subspecialization and approaching things with where people only do mitrals or only do aortic valves. And frankly, in Europe, in many places, that's what has happened to a large extent. A lot of the surgeons, they're just CABG surgeons. They do nothing else but CABG surgery. There's a mitral valve guy, does nothing else but mitral valve surgery. And I think the question is, yeah, looking at the United States, the market, how healthcare is developing, how the hospitals are developing, what makes most sense and what is most doable.
Great. Any, before we keep talking, any questions from anybody in the audience?
I'd like to challenge the panel and make a comment and ask a question. So it seems to me we're way behind the 8 ball when it comes to training our residents and fellows. If you look around us at GYN, urology, general surgery, can you imagine if a general surgery resident graduated from his program, starts his practice and says, I'm going to do my first 100 gallbladders with a subcostal incision, then I'll start doing a laparoscopic gallbladder, or a urologist who came out and said, I'm going to do an open prostatectomy for the first few cases and then start doing robotic. That's absurd. That's unheard of. Why are we so far behind in our graduating residents? They come out and they still have to learn heart surgery, and then after that, they may be able to go to minimally invasive platform. So, I mean, this is a challenge that we have to kind of face, and we're way, way behind, even the GYN surgeons.
Oh,
Mahesh,
I would
Ralph?
push back.
I would totally
Stakes are so
challenge
much higher.
that. And I don't agree. I mean, I think we have a wide range of training programs, and I agree with that. But first of all, there's no open cholecystectomies being done in the U.S. today, so I don't know anyone who could do that operation. None of our general surgeons would even be able to do it. And the reality, and this is the reality, and is the majority of surgery in the U.S. is not being done minimally invasive. I would totally challenge that. Our thoracic guys, even my cardiac fellows, are very good at doing VATS. They can all do it. Because they've trained at our place, they can do mini AVRs, because I'd say about half of our AVRs are mini. We don't, there are things definitely that they don't get trained on, but that's because, our faculty, we can only train on what we do. And the reality is, you're just looking, that pool of residents that are finishing is a reflection of what's being done at our university programs. Now, you could say, I think there's some that are more aggressive in new technology than others, but I think generally they're getting a fairly good exposure. The majority of cases in the U.S. are being done on pump through a sternotomy. And I can tell you, our fellows are really good at doing that. And I really challenge that idea that somehow we have to train people that can do everything. I think it's totally wrong, and that's your job when you hire someone, to mentor them both into learning the new techniques that they may not have been exposed to, and then people have to, your whole lifetime is learners. In your training program, all we're doing, hopefully, is giving them a set of skills and the confidence to be able to learn new operations. I tell my fellows, I didn't learn, I'll go through 2 or 3 weeks and do nothing I learned as a resident. Okay, that wasn't because I was badly trained, because back when I trained, 90% of all the cases were CABGs. We did a ton of them, but we never used anything besides a lima and all vein, and everything was done on pump through a sternotomy. I mean, and there was no minimally invasive. There was no mitral valve repair that I learned. There was no maze procedure, though we were doing it in dogs, but I don't know if that counts. So, I think you're right. And I mentioned, I think there are programs, we do have to work on our training, and that they're clearly training programs that the residents spend a lot of time just watching. And that's, we have to take responsibility for that. I don't think our program is like that. I think they get to do a lot, but with the present, the environment has changed a lot since at least I trained, and Mike could probably talk about that to Emory. Everything's scrutinized, all our results are public, and my young attendings are not certainly as open as I was when I was a young attending, of helping a junior fellow through a case and taking 2 or 3 hours longer, and we're all under pressure. So I think we're evolving but I think overall we do, there's certainly, the problem right now is just a shortage of well-trained cardiac surgeons, and there's a lot of programs. We're not training enough cardiac surgeons as is, but I would say half the programs in the country probably need to either stop training or undergo major revamping so they can keep enough experience. But you know, I agree. I do think there's, you know, we need to look at that, but I'm not sure. It's a hard thing to do when, I mean, the reality
60-second rebuttal.
Okay.
I mean, I was not implying that there were any training programs that weren't doing what they need to do. I think what I'm implying is that somehow the general surgeons figured out a way of doing laparoscopic surgery very easily and successfully, and they were able to train their residents to do it. So I guess the comment would be more geared towards, is our minimally invasive techniques, are they teachable even at this point? Maybe we haven't gotten to the point like general surgery programs or the GYN programs or urology programs. Maybe that's the reason we can't pass it along.
Well, I think they're teachable, and I think we know we can teach it. The problem is the majority, it's different than general surgery where everything's done laparoscopically right now. But in cardiac surgery in the US, maybe not everywhere, the majority of cases are not being done that way. But that's not a training program problem. That's a physician, that's our workforce in cardiac surgery. And I would argue both it's a problem. I mean, why did off-pump surgery fail in the US? It failed. It's a failed operation. It's not done. It failed. It wasn't adopted. In fact, reverse adaptation. I think it's twofold. One, I definitely feel we didn't train people well. We abrogate a lot of our responsibility to industry. But the problem is we have to train the workforce, the non-resident workforce. They're the people who end up teaching people.
I'll echo Joe's comments. I think it's tough to train. First of all, I think we were becoming increasingly complicated and sophisticated in the way we treat disease processes. And I think it's tough to train residents and fellows in 2 years. We have a 2-year program when they have to get certain congenital numbers, thoracic numbers, and adult cardiac numbers. But let's leave minimally invasive aside. I think it's a little bit debatable, but I think what's the elephant in the room is transcatheter skills. I guarantee you that most folks graduating, cardiac folks graduating, don't have a transcatheter skill set, and that's definitely something that's very required in our future, and it's not there. Right?
So Tom, you did a whole year. Do you think you need a whole year still?
I don't think I need a full year of transcatheter skills.
4 months?
I think 4 months is reasonable. 4 or 5 months is reasonable.
Because it's part of the board requirements now to have done some transcatheter work.
But it's a joke. So the board requirements.
It's like 5 cases or something,
It's like, I think it's 10 cases here in the cardiac tract and like 5 cases, and you just really kind of have to hold the wire, and it's not very specific, right?
Right.
But that's the point. I think we need to step back and we realize that most folks out there do a little bit of everything, and you'll have the option if you want to train and choose a pathway where you do a little of everything, so be it. But you're not going to be a specialist. You can do a little of everything, but you're not going to be there doing mixed cabbages and mini AVRs and clips and all that. But then there also needs to be an option for those who really want to specialize, want to do mini maze and mini AVRs and transcatheter skill sets to really to remain relevant, right? I mean, at the end of the day, you know, to stay relevant and keep our field and our specialty alive. And I think it's imperative. If we don't do this, I guarantee you in 7-8 years from now, you know, the valve space, if it hasn't been already, is going to be gone. It's going to be in the cardiology world. I did a SAVR last week, and the cardiologist asked me, well, why isn't this patient a candidate for a TAVR? So the paradigm's changed now. So we actually have to justify SAVR as opposed to justifying TAVR these days. So again, and we're going to talk about this more later on this afternoon, but I think it's important for us to be ahead of the game and learn these new technologies. And you know, some folks who want to do a little bit of everything they can, but it's hard to do everything well.
Mahesh, did you have a comment or?
Yeah. I just wanted to, well, first of all, great comments, and particularly what Ralph had to say about mentorship. Just a brief comment about that is it works the other way as well. In my experience, I have discovered in the last 10, 15 years, having encountered many surgeons who have just come out of practice, in fact, it is the majority of them aren't open to mentorship, which is sad and surprising, maybe. In other words, they think they're fully formed when they you know, emerge from the womb of their residency training program. So that's an issue.
You mean you feel they come out and they're like, I'm done, I'm ready to be by myself. I don't need you anymore.
And I've seen that time and
That's a
time
big
again.
mistake.
Yeah. So that's one issue. The other issue is that
bad way
many
to
of them,
start.
as Sam pointed out, go to smaller hospitals where they don't have the opportunity. But I'd like to put that aside and just mention one thing and make a plea for or make a case for having more advanced cardiac surgery training opportunities, like we've sort of introduced for Moritz a year ago. Now, Moritz had come to this meeting 2-3 years ago and wanted to pursue an opportunity to enhance his skills in minimally invasive and transcatheter, and approached us to see if we had such an opportunity. We didn't have the funding, but the following year we did get the funding for it, and I think it's worked out well. I mean, just to give you an idea, the first 2-3 months that he was with us, I spent time basically assessing his skills and what he was capable of, and trying to teach him the things that I think he needed to know. And then for the last 9-10 months, really every single case has been done by him as the surgeon, with me assisting him. And during that process, well, 2 things have happened. I have learned a lot from him, which I think is inevitable. When you have somebody who is interested and who brings a different perspective to things, you will learn things that you wouldn't have seen yourself, and it's absolutely true. So that's important. But it's also made me realize, and this is to go to Joe's point, to Joe McGinn's point, that it's actually not difficult. In other words, take the example of a minimally invasive AVR. Once you go through the steps of the exposure, it's just an AVR, and going through those steps doesn't take that long. It is a process, and I think that if we had more programs that offered this kind of 6-month track or 1-year track, you would find that you would produce more people that had the skill set that we're talking about.
Great. Any questions?
I got a comment.
Go ahead. Let them give you the microphone because it's being recorded.
Maybe I don't want this recorded. It's Randall Wolf. It's concerning this comparison of general surgery, gynecologic surgery, and urologic surgery to cardiac surgery. It's not a fair comparison, and this is the reason why. Most general surgery and GYN surgery and urologic surgery is ablative surgery. You take something out, you put it in the pan. We don't cut the heart out and put it in the pan. We do mostly reconstructive surgery. And that's why MidCab failed too, because it's not ablative surgery, it's reconstructive surgery. So it's a bad comparison.
If you have a question, please raise your hand, Mariana, on that side.
But I would
and
have to say,
Jennifer.
Here, we got another question. Go ahead.
Hello, David Daniel, local cardiac, thoracic, vascular, obsolete practice model surgeon. Just kidding. So one of the points that I think is interesting to consider as we move towards more and more specialization is there's a lot of things that come up that cross over. I mean, while I've been sitting here, I've been seeing the stream of texts from my group. My partner was called to repair a femoral artery that an impella had injured, and he now has to do a cabbage on the patient. And so you have these sorts of things. And you also have these scenarios where you have a case that you start thinking is just going to be a coronary case, and then lo and behold, turns out you need to do something with the mitral. My concern going forward is, as we specialize and move towards major referral centers for more and more and more of the cases, there's going to be situations that arise where people who come out don't have the crossover training. They haven't really done those things on their own. And that concerns me that in 10 years, are we going to have people coming out who know how to do a coronary really well, but what happens when they got to do something with a valve and they weren't expecting it, and all of a sudden it's like, well, where's the nearest center? Well, that's not nearby. Then the other thing that I'd point out is there's a lot of patients, and it's an area that's important to me because it's really where I kind of make my living. There's a whole lot of people who really don't want to go downtown. I practice 30 minutes away, and you'd be amazed how many people don't want to go. And so I think these are elements that are going to play in going forward with the move towards specialization. And I echo the point that was made before. I think one of the really critical points because of that isn't just about the narrowing down, but also about making things reproducible and teachable so that, I mean, we're all intelligent people. We can pick these things up. I know one of the points Dr. Cooley made before his death when I was at Texas Heart was he did everything, and he thought that it was quite possible to do everything well. Not everybody's Dr. Cooley, but I'd like to think that most of us probably can pick up these skill sets as we go forward without dropping off everything else.
Any other questions?
So I agree with what you're saying, but I think that and I agree with what you're saying as well, Tom. But I'm just trying to put myself in the position of somebody that's finishing 2 or 3 years of a residency cardiothoracic training program, or finishing 6 years of I-6, or finishing 4-3. And I think that you're going to be you have to approach that first job with a lot of humility. And I think what Mahesh was saying about, not looking for that mentorship piece is a huge warning sign for us that are hiring people like you. And I think your focus should be on, established, safe, regular heart surgery. What's regular heart surgery? It's a lot of coronary bypass surgery, which clearly is not going away. It's going to be some aortic valves. I'm a little more optimistic, maybe, but I think we'll be taking a lot of those things out in a little bit, 5 years probably. I think mitral valve surgery is going to be here for a long time, but I know they're pushing into that space. I think when you're in training, if you have opportunities to get transcatheter, like serious transcatheter exposure via an elective or a 6-month fellowship after your training, or some way to incorporate that so you really learn the language. You don't want to just be I can open the groin, but you want to, if you have to open the groin anymore, but you want to know the language that they speak so you can participate, not really in the aortic valve work, but really what's coming quickly is the mitral replacement work, especially. But like you said, you have one chance to leave a first impression. And if you come out in your 3 months, you've had 3 deaths from judgment errors or not asking for help errors, it's irrecoverable almost. So that first year, take it very seriously. Nobody's expecting you to be fast. Nobody's expecting you to know everything. They want you to be safe, smart, have some humility, and respect for the patients that you're taking care of, and ask for help. And if you're joining a practice where you don't think the partners are going to be there when you need them, then you need to go somewhere else before you show up at that hospital.
And I really like those comments, because maybe it's because I'm getting older too, but I really think our training programs, we need to train broadly. And I tried to say that. And it's one of the reasons we haven't gone to an I-6 in St. Louis. We cannot be just putting out even just pure cardiac surgeons. That's not what the market needs in the US. But what I tried to say is, once you get into your practice, and I tell all my fellows, because I have to find jobs for 3 people every year, the first thing they need to assess is, what's the practice looking for? And every practice is looking for something different. If you're really narrowly trained, you may lose a lot of opportunities. If you're broadly trained, at least you have some familiarity with everything. It's your career where you focus. And especially in an academic center, and I think you'd agree, Mike, I mean, we try to get our faculty to all find specialty niches, and I'll send them. We just sent one of our junior faculty to the STS robotic course, because I think that might be a niche at our place for a young person, but we're gonna have to be really careful to mentor her into doing that. But the training, I think, is really dangerous if we start just training super specialists. We have to train people, because I agree totally. I mean, right now when I get called by some of the big groups, even the big private groups, they want someone who's been reasonably vascular trained. Mm-hmm. I would have to say, I don't know how you do Emory. We have our own rotation now that's mandatory, where they just do transcatheter therapeutics, and we used to have an elective, but it's almost everybody's doing that. We've eliminated that. They have to do it, and they cannot. The thing about the trainees, during their TAVR days, they're constantly tried to move it. There's a cabbage that's not covered. I know. Now we've refused to let them do it, but we do TAVR 3 to 4 days a week. On the days that we're not doing it, they're allowed to do it, but I totally agree with you. If they don't come out with good wire skills, and it can't be just, they've got to be able to understand, and our fellows come to the multidisciplinary valve clinics and the conferences so they can understand. I'm not sure you're going to be doing valve surgery at all in 5 or 10 years if you're not also very competent in the transcatheter space.
I agree with Dave, and I obviously agree with Dr. Damiano as well. I don't think they're mutually exclusive. I think we can train broadly and we can train specialists, and I think that's what I'm advocating. I think we need broadly trained cardiothoracic, cardiovascular surgeons out there, But the writing is on the wall, guys. You know, this is the first year actually that there have been more TAVRs than SAVRs and CABGs combined. You know, MitraClip is approved for FMR, right? You don't need a surgeon involvement for clips anymore, right? I have some cardiologists that predict that in 5 years, degenerative P2 prolapse is all going to go clip. It's there, right? It's moving that direction.
Thank you, guys.
Thank you all.
You're not